So weaning parameters. Has anybody heard this term weaning parameters before? Yeah, we don't use it as much, but you know. So historically, weaning parameters started with volume, with vital capacity. So the vital capacity was the first weaning parameter, and still until now you hear some respiratory therapists like the vital capacity is such and such. You just take it from one ear and come out from the other ear. It doesn't matter. You know, don't be nasty. Just say, okay, thank you for doing the vital capacity, but nobody's using it anymore. Don't say that. So vital capacity is basically taking the patient off the vent and putting him, or like decreasing off the vent mode, I mean, and putting him on 5 of PEEP and pressure support of 0. And telling the patient, take the deepest breath you can. Awake patient, right? And if he can take more than 10 milliliter per kilogram, he can be extubated. Obviously, this proved to be not able to be done in a lot of patients, right? So that's why they moved on to the NIF, the negative inspiratory force, and the same thing. You take the patient off the vent. There used to be a gauge, you take him off the vent completely. Now the new vents can do it as a maneuver. You just press the button and say, take the deepest breath you can, same settings. And the patient can take as much as he can. And if he can make pressure more than negative centimeter of water, meaning more than negative 30, 40, 50, negative 60, whatever, that means the patient is strong enough to breathe on his own. Now, these two were the two weaning parameters for the longest time, and the most famous. But using these two, resulted in 70% of patients who extubate themselves, self-extubation, did well. Which means that the intensivists were just looking at them and not doing anything. You know, like we're missing a lot of potentially successful extubations. And that's obviously, okay. So look at imagine a patient in your head. The patient never listened to his mother, never listened to his father, never listened to his teacher, never listened to his parole officer. Why would he listen to you? Why would the patient just suddenly, okay, now I'm gonna change my life with a tube in my mouth and I'm agitated. This like passing by 70-pound resident, he's gonna tell me, take the deepest breath you can. And I'm gonna take the deepest breath I can? No, I'm gonna do like this. I'm not gonna breathe. I'm just gonna go opposite of what she's saying, right? The point I want to make is that this is patient effort dependent. So we don't want patient effort dependent. So that's why they came up with the RESB. The RESB is the Rapid Shallow Breathing Index, which basically you take it's also called the Tobin Index, the same Tobin. And basically it goes in respiratory rate. Yeah, I call Tobin. Tobin is the 4th most famous intensivist in the world. Who's number 1?
Cal.
No. No, Peter Pronovost, right? One of the Klebsi. Merrick, Paul Merrick, and Emmanuel Rivers.
That's fine.
And Tobin. Right? Anyway, doesn't matter. That's the tangent. So what happens is that you take the respiratory rate and divide it by tidal volume in liters. So what you do is that you put the patient on these settings, and in 1 minute, you take the respiratory rate. You don't even tell the patient, because if you tell the patient, it's going to be tachypnic. So what you do, you basically go under the bed or tell them I'm checking the vent or something, and just quickly change it and get out of the room and look. And in 1 minute, look at the respiratory rate and tidal volume. If the respiratory rate is 20, tidal volume is, let's say, 500, that's 0.5, that means the SB is 40. And if anything less than 105, for some reason the number is 105, then you can be extubated. Right? So that's called the Tobin Index, or the Rapid Shallow Breathing Index, or RESB, and that's the classic, what I wrote here. I'm gonna just give at the end 1 minute or 2 minutes to tell you all the modifications that are wrong, that people are using for no good reason. They just keep modifying the SB for their own whatever. Okay? Now, the next one is the SBT, which is also Tobin, right? So all of the above, when compared with SBT, like these three compared with SBT, showed that there is potentially successful extubation that could have been that these are missing, right? It was a small study, but it just makes sense that there's some potentially successful extubation that were missing because the SBT is basically trying to simulate exactly what the patient is going to be dealing with, right? And the SBT is like this: 7/5. He put 40% in his study. I'm putting 60%. I'll tell you that reason when you get older a little bit. And then for 2 hours. Okay. 7 pressure support, 5 FP, 60% for 2 hours. You can use 40. I don't care, but you know, here in this ICU, we don't go down below 60. So why 7, by the way?
Tubing?
Yeah, because the tube is like a straw, and the patient is getting through the straw. So you have to like support just to overcome that resistance of the tube. You don't want to give him any more. You don't want to support him, right? So that's the 7 because of the tube. Some people they get confused, right? And they put the patient on 0/5 because they say we don't want any support. Right? Of course, you're causing more, problem. Like you're putting the patient in the negative, right? But I want to give them the benefit of the doubt when they do that. I think what's happening is that they are trained in tertiary care centers, like everybody, and they just came out of training. And what's happening is that they're seeing that the vents over there, like vents, we have 2 of those vents here, but I'm sure everywhere they have a lot of those vents around, which are vents that have the capability of doing tube compensation resistance, tube resistance compensation, meaning that it calculates the tube resistance and give you an amount of compensation that is only equal to that resistance. So if you have that capability and it's turned on, that means you can do this 0, or you have to do that 0 actually. But you can't go outside in the world because you're not asking the right questions and putting everybody on 0/5 and then wondering, my patients after, when I'm attending, they're not extubating as much as when I was a fellow. That's ridiculous because you're an idiot. That's why, because you're not asking the question. All right, the 5 is the PEEP, obviously. Why 5 of PEEP? Because we know that the vocal cords close before the end of the breath completely, so it leaves a little bit of FRC. If you're violating the vocal cords with the tube, you have to give the patient that, otherwise he's gonna exhale to full. Like everything is gonna come out, right? So that's well known. Why 40%, by the way? Why most of the vents are at 40%? You've seen that, right? Everybody's 40%, that's the natural thing to do. Any idea where that came from? The stupid, okay. So it came from the nasal cannula. So the maximum nasal cannula, the small one, is what, 6 liters per minute, right? So 6 liters per minute, how do you calculate the FiO2? The FiO2 for nasal cannula is basically 6 times 3, every liter is 3, plus 21. 21 plus 18 will give you 39. So that's why all the vents are at 40% from like the beginning of time because of this. Because we know that we want to extubate the patient nasal cannula, so we want to do the test at this level and basically put the patient on 40% and see if he gets extubated or not. If he can't tolerate it, then we wait. Right now we have 15 liter nasal cannula and 70 liter nasal cannula. Why would you apply the same stupid, harsh test? This is, I like the patient actually. We like the patient. We want to extubate the patient. We want to make the test easy. So I think it's no problem to go 60% very easily. 2 hours is 2 hours. That's what Tobin said. 2 hours, more than this. If you put the patient for more than 2 hours on SBT, they're going to have potentially atelectasis. And you don't want to extubate somebody. All right, so be careful of the modification. So somebody will say, when I go to another hospital, somebody will tell me, Dr. Saror, I have the patient on 3/5, no tube resistance compensation, 3/5 for 5 hours, doing great. Been doing this all morning, 5 hours. I said, okay, thank you very much, but please put him back on the vent because I'm not extubating him now. That's the worst time to add more stress for extubation. right? So 2 hours, you have to make a decision in 2 hours. So for example, if you, if the patient is going to, well, let's say here, for example, in this hospital, the culture is a little bit different, the opposite. They come in and they put the patient on 7/5, so the patient is breathing at 40. So they feel bad that the patient is breathing at 40. This is a test. Like if you're proctoring a test, you're not gonna feel bad for people, right? So they feel bad for the patient, so they put them on 15/5. And they will leave them for 2 hours, they pass, and they come to you and say, patient passed the SBT. Then you say, extubate the patient. Then you look like an idiot, right? Can't do that. So that's why we coined the new term. Don't use it anywhere but here. It's called the SPT, right? The SPT is spontaneous pressure trial. And if you tell the nurses here and respiratory therapists, they'll know what you're talking about, right? And if they tell you otherwise, correct them. Saying this is SPT, it's not SBT. SPT is any pressure support and PEEP other than 7/5. So also we don't want to deprive the patient that is breathing in the 40s from having their exercise every day, and so put them on 15/10 or 12/5 or anything you want, and have him do 2 hours and go through it, and then put him back on the vent. That's all. So that's SPT. So the statement is there's no extubation after SPT, but there is a potential extubation after SBT. And you can't have a successful SBT and say, I don't feel like extubating the patient. No, that's the whole point. That's the whole point that made SBT famous, is that it makes the intensivist prediction worth nothing, right? Patient passes SBT, you extubate the patient, right? Unless there's difficult airway or something, other extenuating stuff. All right, so the decision I wanted to get you through is basically the patient tolerated SBT. You know that you can't go more than 2 hours. So 2 hours passed, they says passed SBT. You say extubate the patient, and the nurse says no. I'm going to CAT scan. I don't want to go with him after extubation, so we'll do that. Can we do it after CAT scan? Yeah, that's fine. But you don't continue on 7/5. Make it 15/5. Make it SPT, or put him on the vent back again, AC or whatever you want to put him on. And when he comes back, you can extubate him without repeating the SBT again. Okay? So we're done with that. In the last minute, as promised, I'm going to tell you about the RESB, right? The modification of the RESB. I don't know why people keep modifying the RESB. I just don't get it. For example, one of the most famous ones is to tell you, put the patient on 7/5 for 2 hours and tell me what the RESB is. So basically, as if they're doing an SBT for 2 hours, and that's very famous, and they tell me the RESB. And but I can tell you exactly why this is happening from an attending point of view. It's happening because they don't trust the residents. Unfortunately, right? They don't want to hear your opinion. Like here, if you tell me the patient looks good on SBT, I will 100% say extubate, right? Because I want to extubate more. Remember these statistics? This didn't disappear. There's still a good percentage of patients that can be extubated, and we still not extubating them, right? So if you tell me, if you're in your assessment, patient looks good, can be extubated, I'll extubate the patient, right? But some attendings want to, so they want to say, tell me the RESB after this, meaning that you basically want you in one word telling what the respiratory rate and the tidal volume is. They just want to hear a number, so this way it can be a little bit more objective. Another modification of the RESB, which people for some reason they do 0/5, but not for 1 minute, for 30 minutes. Nobody ever said that. You're bound to fail. 30 minutes without any support, right? Some people go even for 2 hours. And some people go in Boston 0/0 for 2 hours. That's crazy. That's crazy, all of those modification, and the last modification, which really there is a study about it actually. I don't know why would we do that. They do a RESB 0/5, and they do it in 1 minute, like the regular one. So it comes out like 40. So it passed. The patient should be extubated now, right? And then you repeat the same thing 0/5 at 30 minutes, and it comes out, let's say 60. Still passed, but they don't extubate. They say it's going up. of course it's gonna go up. You're not gonna extubate anybody, right? So I don't do any of this. If you see something like this, just call the person on it. Just say, what is the Tobin index? Print me the lecture. Print me the literature. Huh? And you'll find that Tobin index is 1 minute, blah, blah, blah. We're gonna stick to it, right? So I don't use those, but I use the SB a little bit, right? I mean, this one is the key, obviously, right? But you can use the SB in very limited circumstances. I don't use it on everybody. Huh? And where are those circumstances? If the patient, if I think that the patient will potentially be hurt by the SBT, somebody with like uncontrolled cardiac ischemia or arrhythmia or something like that, that if I give him 2 hours of SBT, he might actually go into ischemia again or arrhythmia. So what I do, I just give him 1 minute of SB, right? Make sure that he's like a peach, looks great, then I put him on the SBT. And that's the only time you should use the SB, in my opinion. And that's it.